Welcome back. In our first explainer, we laid out the foundational frameworks. Today, we are diving deep into the real diagnostic engine, the history of presenting complaint. This is where we learn to take a broad symptom and refine our diagnosis with, well, surgical precision.
So let me just start with the question that really gets to the heart of what we're doing today. How is it possible that asking just one simple thing, how fast did the symptoms start, can literally shrink your list of possibilities from maybe a dozen down to just 2 or 3? Well, that's the incredible power of structured questioning, and that's exactly what we're focusing on.
We're going to tackle this using a concept I like to call the diagnostic funnel. Just picture it. We start at the top with that broad, often really vague symptom of dizziness, and then, by applying a series of precise filters, we funnel our way down, getting more and more specific until we're left with a high-probability diagnosis. Let's build that funnel together.
Okay, the very first and, arguably the most powerful filter in our entire funnel is timing. Just by carefully mapping out the onset and the duration of the symptoms, we can immediately start to categorize the whole presentation into one of the core vestibular syndromes. It's a huge first step.
What's so amazing about this is how it cuts through the complexity. The titrate framework really boils down all vestibular presentations into just 3 of these temporal syndromes. So first up, you've got acute vestibular syndrome, or AVS. That's an abrupt, continuous spell that lasts for hours, maybe even days. Second, there's episodic vestibular syndrome, EVS. These are distinct, repeating episodes with totally symptom-free periods in between. And finally, chronic vestibular syndrome, or CVS, a persistent dizziness that's been hanging around for weeks or even months. Figuring out which bucket your patient falls into, that is the crucial first move.
This timeline just brilliantly shows how useful duration is. Let's walk through it, right? Episodes lasting mere seconds, we're immediately thinking of BPV, benign paroxysmal positional vertigo. What if it lasts a few minutes? Well, that points us towards a TIA, or maybe a migraine aura. Stretching into hours, okay, now we're in the ballpark of Meniere's disease or vestibular migraine. When it's continuous for days, that's classic acute vestibular syndrome, and we've got to consider neuritis or even stroke. And if it's been going on for weeks to months, now we're looking at a chronic syndrome like PPPD. You see? With just this one filter, we've already narrowed the field down so much.
And this table just adds another layer of detail. For those seconds-long spells, the key question is there a reproducible trigger? For the 20-minute to 4-hour episodes, we're looking for distinguishing features, like the oral fullness you see in Meniere's, or neurological signs that might suggest a TIA. For symptoms lasting several hours, things like headache and photophobia just scream vestibular migraine. And for those chronic cases, you've got to ask if symptoms get worse in busy visual environments. That's a huge hallmark of PPPD. Every little detail sharpens our focus.
Now here's a clinical pearl you can take to the clinic tomorrow. This is an incredible statistic from the source material. Nocturnal vertigo, specifically when a patient tells you they were woken up by it after turning over in bed, has an odds ratio of 60 for BPV, 60. Just asking that one simple question, does this ever wake you up at night when you roll over, can give you just a massive amount of diagnostic confidence. It's a perfect example of how powerful targeted history taking can be.
Okay, so we've established the timing. The second filter in our diagnostic funnel is triggers. You see, if a symptom is being provoked, identifying that specific stimulus helps us unlock the underlying pathophysiology. It tells us why it's happening.
The key here is just to be systematic. We need to screen for these 6 primary trigger categories. Is it positional? A change in head position relative to gravity. Is it caused by active head motion? Is it visual motion, like scrolling on a phone or walking through a crowded supermarket? Could it be sound or pressure-induced? Is it orthostatic, happening only when they stand up, or is it exertional? Every one of these questions points us down a totally different diagnostic path.
And this slide, well, this shows you the diagnostic payoff. Positional triggers, bam, that strongly suggests BPPV. Dizziness with active head motion points you toward a VOR deficit. If visual motion is the culprit, we start to suspect PPPD. And that sensitivity to sound or pressure, that's a classic sign for a paralymph fistula or superior canal dehiscence. And of course, if the episodes are truly spontaneous with no trigger at all, that keeps diagnoses like Meniere's, vestibular migraine, and neuritis right at the top of our list.
We've got timing, and we've got triggers. Now for our third and final filter, and this one is absolutely critical, associated symptoms. This is where we screen for the clues that help us tell the difference between benign peripheral conditions and potentially dangerous central ones. This is where we find the red flags.
So we need to probe 4 key domains here. First, auditory.
You have to ask about hearing loss, tinnitus, or that feeling of oral fullness, which all point toward conditions like Meniere's. Second, neurological. Look for things like headache, double vision, slurred speech, or weakness. Any of those is a major red flag for a central cause, like a stroke. Third, autonomic symptoms like nausea. And finally, psychiatric. Is there a history of anxiety or panic? Because that's strongly associated with PPP.
All right, let's just focus for a second on a really vital clinical distinction regarding nausea, because it can feel a little counterintuitive. You might think more severe symptoms mean a more serious problem, but with vertigo, it is often the exact opposite. An acute peripheral lesion, like vestibular neuritis, usually causes severe, really intense nausea. But in contrast, a central lesion, like a stroke, can cause profound imbalance. The patient can't even stand, but with surprisingly minimal nausea. That mismatch is a critical warning sign.
So here's the takeaway, the clinical pearl. Use nausea severity as a quick bedside filter. If your patient is incredibly nauseous, but they can still walk, you should be thinking peripheral. If they can barely stand up, but tell you they only feel mildly sick, you have to have a high suspicion for a central cause. This is a rule of thumb you can apply immediately.
All right, let's put it all together now. We've moved through our diagnostic funnel, we've applied the filters of timing, triggers, and associated symptoms. We're now at a point where we can synthesize all this information into a complete diagnostic picture, one that has a really high probability of being correct.
So let's recap the core takeaways. First, timing is your first cut. It maps the presentation to a syndrome, acute, episodic, or chronic. Second, triggers are your key to unlocking the mechanism. They tell you why it's happening. And third, associated symptoms are your safety net. That's where you find the critical red flags. Timing, triggers, and associated symptoms. That is the core of an effective HPC. Now, this gives us a really powerful framework, but we're not quite done. In our third and final explainer in this series, we are going to integrate all of these concepts into a complete, structured 10-minute protocol. We'll also do a much deeper dive into red flag recognition and the crucial roles that medications and past medical history play in all of this.
Thank you so much for joining us for this deep dive into the history of presenting complaint. A systematic approach really is the key to getting diagnostic clarity in vestibular medicine. To explore more on this topic and to get access to a ton of materials for both clinicians and patients, please visit AustralianDizzinessClinics.com. And hey, if you found this useful, please subscribe to our channel and maybe consider leaving a rating. It really does help other clinicians find this series. We'll see you for part 3.